In prepping for this session, we were reminded a number of times that we have the largest panel, which for me as the moderator means my preamble is going to be quick, and I'm going to watch the clock to make sure that you can hear from this incredible panel. And I say that because this panel not only is going to talk about anchor institutions and the role that they play in cities, but more importantly, what you're going to hear is some of the most innovative thinking about what it's going to take to improve health and well-being in our cities. And what is incredible about this very esteemed panel is that I think only one of our panelists would identify as a doctor, a medical doctor. We have venture capitalists, we have city planners, we have community development leaders, public health practitioners, and that expertise represented here. And I say that to make the point that what it's going to take to improve health in our communities, in our cities, is not something that's going to happen in the doctor's office alone. We increasingly are looking at the conditions in our cities. We're looking at the built and physical environment. We're looking at transportation, stable and affordable housing as the conditions that are going to, in some cases, influence our physical and mental health directly. But in some cases, it's how those conditions create the opportunities for us to be healthy and well, the opportunities for us to have access to healthy food or safe places to play and exercise, the opportunities to live without the fear of displacement or eviction, or the stress that comes with raising children in an unsafe neighborhood. And when we look now at cities across the United States, what we often find is that you can walk a couple blocks, a mile, and in that short walk, experience and see and know a difference in life expectancy from one neighborhood to the next of 10, 15, 20 years. And if you stop to think about what you have done in the past 20 years of your life, the contributions you've made to your community in that amount of time, that's the difference, that's the gap that we see neighborhood to neighborhood. And those neighborhoods that have lower life expectancy, have poorer health outcomes, are not surprisingly oftentimes those neighborhoods, those communities of color, and those with lower income. So these are not easy problems. They are not problems that can't be solved. But to solve these types of problems, we need a new type of leadership. We need a new type of leadership from health and healthcare institutions, and we need new types of partners. Partners that come from planning, that come from transportation. So that is really what this conversation is about. So we're going to start our conversation today with Robin Hackey, who is sitting right next to me. Robin is the director of the Center for Community Investment, and she and her team over the past couple of years have been scanning the nation to look for, talk with, work with those healthcare institutions that are at the leading edge of this work. So she's going to give us the bird's eye view. And then we'll have the opportunity to hear from two systems that are really pioneering in this space, and pioneering in the space of thinking differently about what the role for a healthcare institution, a healthcare anchor is in the community. And not just about community partnership, but really thinking about investment and changing those community conditions. So we have John Vu, who is the National Vice President of Strategy for Community Health at Kaiser Permanente, based here in California. And we have Dr. Sam Ross, the Chief Executive Officer of Bon Secours Baltimore Health System, now Bon Secours Mercy. And then lastly, we're going to hear from Maggie Superchurch. Maggie is the Vice President for Market Innovation and Impact at the Conservation Law Foundation in Boston. And Maggie is the mastermind behind the Healthy Neighborhoods Equity Fund and a companion research study. And this is an equity fund that's focused on investment in transit-oriented development. but it does so with an eye on what the impact on health will be. And her team have been using that as a way to have conversation with healthcare systems, and she'll be able to reflect on what that means in terms of the health data that's necessary to have those conversations, and the health impact as it relates to residents and their engagement in these conversations. So with that exciting lineup ahead of us, I'm going to turn it over to Robin to share a little bit about what you have seen and what you're learning as you look across the country.
Great. Thank you very much. I'm the reformed venture capitalist in the crowd. And a couple of years ago, the Robert Wood Johnson Foundation asked us to take a look at how hospitals and health systems were behaving in new ways that were going to promote conditions of health in communities across the country. And what we looked at were, what were the investments being made beyond the walls of the health facilities, so out in the community, and what were the investments that were being made that were not actually clinically oriented. So they were not about disease prevention directly or about health services. Not that those things aren't important, but that was not the focus. And we were also talking about investment not in the poetic sense of, we invest in our children's future, but investment in the sense of like money, which is how venture capitalists think about the world. And so what did we see when we looked for those investments? What we saw was that there were a small number of pioneering systems, including the ones that you'll hear from today, that were building or preserving or rehabilitating affordable housing, and doing it at a scale that was meaningful, hundreds of units, not 3. We saw systems that were investing in or even operating grocery stores to provide fresh food in what would otherwise have been food deserts. We saw people using the strength of the anchor institution to provide guarantees to loan funds that were being made to put together to finance affordable housing. And we saw the leveraged use of grant funds, which are sometimes referred to as community benefit funds, to help create an environment where financial investors like banks and others would feel comfortable coming into the structures. So these are not the kinds of activities that you would normally expect a healthcare organization to be doing. And in fact, it was a very small, and still is a very small portion of the health institutions in the country that were doing this behavior. And so as a venture capitalist, we have often said that the future is here now, it's just not evenly distributed. And so we were really consciously looking to see what was going on at the very edge of practice so that we could understand what was motivating that, what would we learn from it about what we could do to help others get to the same place. And so what did we see about why these institutions were doing what they were doing? They were not doing it because it was mandated, because it isn't. And they were not doing it because of the transition that many people talk about from volume being paid for the number of procedures that you do to value, where we're looking for ways to improve quality and health without just doing more procedures. Because that transition, which people, I think, believe is going to happen, is at a very early stage. So why were they doing it? Well, the first reason for many of the systems was really about mission. That if they defined their mission as promoting health and not delivering health care, then as soon as the research said that the conditions in community were what dictate people's health outcomes, then that was obvious to them that that's what they would be doing. And some of the faith-based systems, and in particularly the Catholic healthcare systems, were very clear on that, but it was not only the faith-based systems that had that passionate attachment to the mission. The second reason, which was surprising to some of us, was what we would call political or institutional interests. So anchor institutions, hospitals, and health systems really depend on the place that they're in thriving in order for them to be able to thrive. And having a network of relationships with the mayor, with the city council, with others who could make decisions about zoning, about workforce subsidies, about all kinds of things not directly involved with health, was really important to advancing the institutional interests of these hospitals. And so they were enlightened civic leaders. They said in order to be competitive, attract patients, attract staff, we want to be part of a thriving community, and we'll do what it takes to bring about those kinds of conditions. And then the last motivation, which was really the narrowest and the one that we expected to be the most prevalent, was pure finance and economics. In other words, we're doing this because of ROI, because it's a good economic thing to do. And the fact is, it is a good economic thing to do, but proving that is really difficult given the conditions around data and what does it mean to avert services from a high utilizer? What does it mean to invest in mold remediation so that kids with asthma don't end up in the emergency room? Again, it's a great investment, and the people who were measuring it found that it was a great investment, but it's hard to measure. And so these other two motivations, which were broader, tended to be more prevalent and articulated more strongly. What we found also that was interesting was that the health systems that we were talking to were using a really broad array of their own assets. So community benefit grants, for sure, but also investment assets, so cash reserves, insurance reserves, operating profits, and also land and expertise, development expertise, financial expertise. They were really harnessing all of the knowledge and all of the assets of the health system to put to use for the community, which was really a powerful contribution to the community investment system. And we saw that they were doing this work not alone, but in partnership with others in the community. So I think I'll leave it at that stage, and we'll come back and hear from the folks who are doing it.
Great, great. So John, I'm going to turn to you. Kaiser Permanente is known here in California in the region. You're known as delivering healthcare, paying for healthcare, and have been a leader in community health. Earlier this year, your organization made an announcement, $200 million commitment to addressing housing affordability, stability, not the type of announcement we tend to expect from a healthcare system. So tell us a little bit about the vision for your role in changing community conditions and how the organization is working towards that.
Yeah, thank you. And good morning, everyone. You both so beautifully framed all the issues, and I think we have wholeheartedly adopted the motivations, the way we think about health differently. And that vision very much is one that we've had in many ways since our founding 74 years ago, but continues now in terms of that health is more than just healthcare, and we need to move as an industry really away from just being models of sick care, but to really being producers of health for people. And we realized about 7 or 8 years ago that being a producer of health means bringing every single asset to bear on this that we have as an organization. So all the world-class healthcare that we could deliver is great. All the prevention and the screenings and the mammographies is great. The labs, the pharmacies, the good coverage that we could provide people. But in addition to all of that, we're here to fix you when you're broken, but how do we keep you healthy? We have many other powerful assets, which could include the way we hire, the way we purchase, the way we use our investments and treasury dollars. And so, sorry about that. So using all of these assets, one of them being our treasury assets that Abby referred to, was we went to our treasury department and said, we've got all these billions of dollars in Wall Street. Can we start thinking about how to direct it to Main Street a little bit more? And the Main Street's in our neighborhoods. We're in 9 states and Washington, D.C. We've got, $80 billion of revenue every year. How are we directing some of that money towards our communities this way? And so we made this initial announcement around $200 million with the focus on affordable housing. And we are going to work with partners who know how to do affordable housing really well. We are not specialists in it at all. But we could bring our voice, we could bring our resources, we could bring other critical sort of thinking to it. And that's kind of the model behind that. But everything that you've outlined in terms of how healthcare could be thinking differently about the way it thinks about health is very much the mindset that we've got at this point, in bringing total health to people, not just sort of repairing them when they're sick.
Great. So we're going to head down to the other coast in some ways. Dr. Ross, you're based in Baltimore. Bon Secours has been doing community work in Baltimore. I think you've developed over 800 units of affordable housing as sort of a part of a larger strategy. You're looking at where that goes next, where that goes throughout your multi-state system. So tell us a little bit about, again, the vision for how the hospital shows up in the community, changing conditions, what you've learned along the way.
All right, thank you. Am I on?
Mm-hmm.
Okay, good. Just one acknowledgement, just like one of the previous speakers, I didn't bring a brush or a comb today. But our vision started long before I got there, with the Sisters of Bon Secours. They came to this country in 1881 in Baltimore. They did home care. They were the first visiting nurses before there were visiting nurses. And the hospital was only established 40 years after that arrival. But the vision, Thomas Edison said, vision without execution is a hallucination. And so the thing I can say about our organization is that those sisters had vision, and then over time, in bringing on other leaders, it really became about execution. So in 1995, again, as the system looked around as to what was happening in Baltimore, Baltimore used to be a city of 1 million people. It's now a city of about 650,000 people. And so there are a lot of vacant houses, and in our immediate vicinity, a significant number. So it grew out of community engagement and community involvement. Somebody was talking about this earlier. If we're going to be community responsive, then we have to not just talk to people, but we have to listen to people, and what they say has to make a difference in how we operate. So the key phrase that I learned, I've been in Baltimore now for 12 years, was rats and trash. Because when they did the community engagement activities back in the 90s, the number one problem that the community said existed was not heart disease, was not diabetes, was not cancer, and all the things that our statistics tend to say, but it was rats and trash. And the reason that there were rats and trash was because all the vacant, boarded up buildings that surrounded our institution. And so they made a decision consciously at that time to address health in a non-traditional way. And so went about buying up some of these vacant buildings and then working in partnership primarily with Enterprise Community Foundation and doing this through low-income housing tax credits to begin conversion into family housing units that are based on income, family size, and then also a number of senior housing facilities that are, again, based on affordability. So our vision began really through community engagement and what the community said was important. And as you mentioned, we now have 802 affordable housing units. Our goal over the next 5 years is to get to 1,200 and look at the different ways that we can fund those going forward. So continuing to be responsive to what the community says the needs are, and trying to bring other partners on board, like Kaiser. We have an initiative actually with Kaiser in the Mid-Atlantic right now that we're working on the social determinants and looking to bring other partners into that equation.
So, Dr. Ross, both for you and John, this question of partners is relevant in part because if you think about the capacity that's needed within the healthcare system to do this type of work, is that capacity that you're building within the organization, knowing how to put these deals together, knowing how to think about engaging with the community, or are you relying with other partners, other institutions to do this type of work?
So we feel like we had the best capacity around the community engagement piece. I mean, that's, if we have an expertise, that was it. Because, and I get asked this all the time. One of my friends, he's the vice president at one of the banks there, and he says, why do you care about this other stuff? And I made a point to him that any business in regardless of what area you're in, you want to be in a thriving community. You want to be in a stable community because that impacts your stability. And someone said a long time ago in another presentation, they said, you can have success in the marketplace, but not improve the health of the people. And I think in healthcare, that's what we discovered. We got money in the bank and we've got a lot of things, but if you look at the statistics, RWJ, community health rankings, et cetera, around us, we haven't improved the health of the people. The emergency room doesn't do it. Inpatient activities don't do it as well. And so initially we, again, working with Enterprise, had to gain that expertise around, how do you put together tax credit deals? And so we started with one employee, again, and then working with the Enterprise and other consultants to do that. So today, we still only have 2 employees that work internally to do that, but we are the developer in this process. And then through Enterprise and others who are investors, they help with the tax credit portion of it. And we continue to build really through those partnerships and those relationships. And that includes the city and their housing activity. That includes the state and their housing departments, et cetera, along with the federal government.
Can I address that for 1 second? One thing that we saw in the hospitals that we've been working with as part of our program is that if you don't bring into the hospital system at least one person with a non-traditional background, either development experience or community development experience, it's really hard for the partners to have somebody to attach to. And so having grown up in New York, there used to be a commercial on TV that said an educated consumer is our best customer. And so there needed to be somebody in the hospital system who could be an educated consumer, because that gave the Velcro to the community partners to stick to.
Yeah, I would echo sort of in between both of those, because it is hard to find that sweet spot of having staff and expertise in-house to do this, but not getting bloated and realizing also the humility that we don't know it all. You're a reformed venture capitalist. Now I'm a wannabe venture capitalist. But people still don't want to talk to me. They want to go talk to our treasury people when we start talking about these deals. But they're managing the core business. And so how do we kind of direct some of that time? So that is one of the main key things, is to find that balance of how do you build enough just inside so that you're smart enough to be at the table and people want you at the table, but that you don't have to be like creating all these tables inside as well.
All right, Maggie, I want to turn it over to you. We've talked a little bit about the motivation for healthcare systems to think about investment in changing community conditions. You come at this from thinking about what are those investments and how do we track whether or not they impact health. So can you tell us a little bit more about the Healthy Neighborhoods Equity Fund, your vision for that, and what you're learning about working with healthcare systems?
Sure, thank you. Great to be here with you all this morning. Before I talk about the fund, I just want to say a word about my background. I'm the planner. Everybody's sort of owning their space here, so I'm the person who started in city planning, design, and development. And I was working on a very large, complicated, ambitious real estate project in the depths of the recession. And probably 3 or so years in, my husband, who works in healthcare data analytics, said, "You do understand that one failed diabetes trial would pay for everything you're trying to do overnight, right?" And I was like, "Really? It's really like," he's like, "No, really, it is that." And we were struggling to put together $30, $40 million. The project ultimately got done, but that conversation, along with great work that folks on this panel and many others were doing, to really think about this connection between health and place and all the things that happen outside the clinic walls that determine how well we are and how long we live, stayed with me and really was part of the motivation to think about how we take investment funds, how we take planning efforts, how we work with community organizations in a way that really intentionally focuses on health and well-being. And one of the things that comes up early and often in that conversation is the use of data. So at a sort of 50,000-foot level, I think there's broad recognition that place matters for health. Many of you have probably seen the statistics about 10 to 20% of how long you live and how well you live is what happens sort of in the clinic walls or in the hospital. About 30% is genetics, and the balance are social and environmental factors, many of which happen in place, right? So the rats in the trash or the lack of rats in trash. Education, access to services, the ability to get around, the quality of your housing. Can you, eat healthy food? Can you get healthy food? The choices we have are really a function of the choices, in the larger community, many of which we don't often have direct control over. So all of that being true, the question, as I and colleagues from my organization, Conservation Law Foundation, and other partners in the Boston area, we're thinking about some of these issues in relation to transit-oriented development. So there was a presenting challenge, which remains a presenting challenge in our region, as in many large metro regions, which is that we know where development should go, where we want housing and jobs. We know that those need to be available to a broad range of people and not just the most wealthy. But that's not actually what we produce, right? What we produce is a combination of either, in many cases, very expensive high-end housing in great locations, tax credit subsidized housing to the degree that those subsidies are available, which is critically important, but there aren't enough subsidies even yet, and continued development in communities that don't have access to transit, don't have access to services, and many of them really functionally gated to lower income people and communities of color. So there's a mismatch between sort of where we think we should build and what we build, and one of the drivers of that is finance. So the challenge we were trying to solve in creating the fund was to say, how do we deliver a different kind of investment that can stay in longer, take a little more risk, accept a somewhat lower return, to support projects in communities that have affirmatively said, we want a mix of housing, we want a mix of jobs and commercial space close to transit, and we've assembled some of the resources, but we need more. And so that was really our target for creating the Healthy Neighborhoods Equity Fund. And in the course of those conversations, what we realized was that creating equitable transit-oriented development wasn't the goal, it was the means to an end. And the end was to create healthy neighborhoods. And that frame shift was really important, and one that I think many of us who had been in housing and community development and finance for a long time was pretty profound, but presented a challenge, which was, well, if we're going to screen investments and we're going to understand impact, what do we even measure? How do we begin to unpack this whole set of questions? So we tackled that through the lens of a health impact assessment, working with some terrific partners from the State Department of Public Health and our regional planning agency to say if we took 3 sample projects that represent the kind of investment that we would be looking to make through the fund and asked, how would a project like this or investment like this impact health, for good or for bad, in some cases maybe both, and sort of broke down the various factors inherent in those projects that would drive health, not just for people who lived in those units or had access to those jobs, but really for the whole neighborhood. And that process and the findings of that health impact assessment gave us the foundation to build a scoring system that we now use for the fund, to both evaluate projects on the front end and then generate some baseline data on the back end. So as those investments happen, projects are built, money's in for about 10 years, what's happening over that 10-year horizon, how are neighborhoods changing, and how are the projects evolving? And part of that was getting to this question of health data. How do we actually know how healthy people are in a given place? And so we went on a journey to kind of understand that health data landscape. I think it's getting easier to answer that question. I'll give a plug for the work that Abby and her colleagues have been doing to pull together data on life expectancy at the census tract level across the entire country, which is a phenomenal resource that's only been recently available. We had to pull some of that data from prior studies, and it was very limited in scope. But I will say that in talking to investors, real estate investors in particular, who understood why we were talking about housing, why we were talking about transportation, but as soon as we said health, started scratching their heads like, am I in the wrong presentation? I thought you were pitching a real estate fund. But the statistic that got them was this life expectancy gap that Abby talked about, which really begs the question, why? Why do we see these huge differences in places that have the same functional economy, many of the same resources within a few miles? And this idea that community conditions are so important for how well and how long people live then sort of opens the door to this bigger conversation about, well, why, and what are the other factors that are going on, and how do we measure that, and how do we target investment? So I'm happy to say the fund is close to fully deployed. We've invested in 7 projects in Eastern Massachusetts, including Boston and other communities connected by transit. And each of those communities are places that have said, we want this kind of development, and but for this access to capital, this would be very difficult to do. We're thinking about how to adapt our scorecard system based on what we've learned from the first fund. But importantly, what we're learning through a research study, which Abby alluded to, which we launched at the same time that the fund was being built, in recognition that there was a lot we knew about health in place and an awful lot we didn't know. And in part, we wanted to be sure that as we explored those questions, we did so alongside residents who were in those communities, experiencing that change and kind of what that felt like to them and how they understood what health meant and what kinds of conditions would generate health. So that study is ongoing. The first baseline paper was published in June. And we're using participatory action research with a number of residents and community-based organizations to really try to unpack some of these issues and finding some really interesting early results in terms of the things we should probably measure that we don't typically measure and that the health system has no visibility into. So happy to talk more about that, but thank you.
So, I mean, one of the things I think you can take from hearing our panelists is that there clearly is an increased recognition, you know, across the nation about what it is that actually is influencing health in our communities. Many of you, those of you who have followed, you know, work of Raj Chetty and his colleagues have also, you know, really put the emphasis on the impact that it has, particularly on young children, and how poor neighborhood conditions, the impact it has on poor children and their lifelong health. So if you're thinking about the future trajectory of your city, your region, your workforce, paying attention to what's happening in our neighborhoods now is really essential. So that's well and good. Well, not well and good, but the fact that it's increasingly well understood, I think, is an important step. The type of leadership and engagement that we're seeing from institutions like Kaiser Permanente and Bon Secours is still pretty novel. It's still new, and it's certainly not ubiquitous in cities, you know, across the country. So as I look out in the audience, I imagine that most, if not all of you, are in cities where there are major healthcare institutions and hospitals. And so I want to ask the panelists, sort of recognizing that, you know, what are the steps, right? What's the practical guidance we say to both, you know, those in healthcare certainly, but those who are working on changing neighborhood conditions in either, you know, how to work with healthcare institutions, how to, you know, enable the policy change, to think about the data needs, the financing. What is the sort of the takeaway that we can walk away from this conversation with that we might share in kind of moving the conversation forward? Robin, you want to take a stab at that?
Sure. So I think the first thing is to recognize that there's a kind of language and culture gap. And one of the ways to help bridge that language and culture gap is to read a publicly available document called the Community Health Needs Assessment, which every nonprofit hospital has to do once every 3 years. It's on their website. And that will allow you to see what the hospital thinks the needs are of the community, which may or may not be the same as what you think the needs are, but at least it allows you to make the case in words that are resonant inside the healthcare system. The second thing I think we've found is that it's really good to make it easy for the hospitals and health institutions to play. And so what that means is if you can bring an investable opportunity, an affordable housing development or a grocery store or some other concrete project where there is a way for them to get involved, not just through grant making necessarily, but as investors, it's good to have a concrete thing to look at. And what we've seen a couple of times, I think, including with your fund, is that they may reject initially a perfectly good investment opportunity for their investment dollars, but they may decide to do it with their grant dollars, which sort of gets the toe into the water, which is the right direction for the toe to go. And then I think the last thing we would say is that engaging senior leadership from the hospital and not just the community relations folks is helpful. And using examples from the field, saying, hey, you know, you're not breaking new ground here. This is something that is a perfectly acceptable thing to do. And look, you know, there are live examples of how it's done. We catalog a lot of those examples in a paper that is on the Robert Wood Johnson website about actors, the health system as actors in the community investment system. And so it's easy to be able to point to different examples and say, you know, like this and like that, rather than you have to make this up.
We'll go down the line. Maggie, what do you think?
So, you know, I would say one of the lessons for us is really figure out who your allies are. You know, everything starts with human relationships. Boston Medical Center was an investor in our fund alongside a number of regional and national banks, high net worth individuals, philanthropy, public sector, and to Robin's point, it wasn't ever going to stack up as a sort of investment that would compare favorably with a traditional private equity investment that the you know, treasury and portfolio folks would make. But as a mission-based investment, it was a very attractive proposition, both because we were thinking about measurement and we could say, for example, we know what rates are for chronic disease and mental health and things that the system understands in this geography, and here are some projects in this geography that are attempting to challenge and sort of turn the tide on some of those statistics. So that was important, but all the data in the world would not move things if we hadn't had several very, very focused champions internally. Two physicians, Dr. Megan Sandel and Dr. Thea James, who were just relentless in their determination to see the hospital do more and do better, and to meet their mission to make Boston the healthiest city in the nation, and importantly, address health disparities and health equity. So I think knowing kind of who your champions are, who your allies are, in my experience, they're often physicians, because those are the people who see those presenting challenges. Interestingly, they're almost always pediatricians, not surprisingly, I suppose, because when you see a sick child who's going home to a place that has no heat and rodent infestation and lack of access to food, those are issues that keep you up at night. But also senior leadership, to Robin's point, a lot of people weigh into these decisions. So figure out who's on the boards, figure out who the physicians are, who's really thinking and talk about these issues, and bring them to your table, walk around your neighborhoods with them, get to know them, because that, I think, is then when sort of all the data and the strategy and the examples become relevant, but you need to have the conversation first.
I always like listening to Robin and Maggie talk, because they feed me every single talking point that I need to. It helps remind me why I'm doing what we're doing. So I echo all of that. The champions, the leaders, the data. I mean, healthcare, you can imagine, very analytical. You bring the right data. And it really depends. I mean, if in your area or whom you want to work with, they aren't as kind of forward-leaning and ready to engage, I think all of those things are really helpful and handy. In places where there's active institutions like Bon Secours and others, then it's a matter of, I think it falls more on us in some ways, and it's a two-way street. Like, we have to kind of help you all see, or people who are working in other domains or other sectors, see why health matters. Why designing the next, light rail matters to health, why the food system matters to health, why the street design matters to health, on and on and on, and work-shaping policy, getting health into the general plans of cities. Those are the kinds of things. Why technology matters, why AI can apply to big community-level change. And those are the kinds of things we want to start sort of provoking as well from our end.
So I would just say, I had an executive physical a few years ago, and even though I'm a physician, I'm a recovering family physician. But he said to me, he said, "So are you here today because you just want to know, or are you here because you're ready to do something about it?" That time I said I just wanted to know. But I'd ask that question to this group today, because that gets to what you're bringing up. Because all the things that have been said are the ways that you can begin to help do something about it. Go to your websites, the hospital systems, health system website, and look at the community health needs assessments, because it should say what the community has identified as the issues that the health system's chosen to hopefully implement some interventions. They all have advisory boards, typically, and so maybe your opportunity is to become a member of the advisory board, because something in that plan touches on a major focus area of your organization or your interests. And then I think in so doing, you become part of the solution, because we all know what the challenges are, but we don't have all the resources. So sometimes it is bi-directional. You educate us, we educate you, and we get a better product for improving the health of the community. So don't be afraid to see what it is, and don't be afraid to approach healthcare leaders and say, "Hey, I want to help." We give tours now at least once a month, and we've had people from T. Rowe Price, we've had people from other investment, Brown Advisory and others, and once they come, then those leaders say, "Oh, here's how we can be part of investing or bringing other people to the table to invest in the things that are going to help with community and economic development in our particular community." So start with the CHNA, and then talking with the leaders and figure out what the role is that everybody can play, because there's a part for everybody. This is complex enough around social determinants that we all have a part in this.
Yeah, and just one point on the finance angle is there is such a thing called uncorrelated assets, right? And when the stock market tanks, as it has done this month, I've heard more than one foundation say to me that the asset class that has outperformed everything else in their portfolio is affordable housing investment. And so if you're talking to the finance people, if you don't want to make the health argument, you make the uncorrelated asset argument and see how that goes.
Well, I know we're coming to our time. I want to thank our panelists, not only for being incredible panelists and sharing their work, but for the incredible work that they're doing in changing the way that we tackle health in our cities around the nation. We're happy to talk more over lunch, and join me in thanking our panel.